All right. Welcome. Let's talk about some OBGYN. Adolescent confidentiality is one of the most trusted medical legal principles in reproductive health, and it sits at the beginning of many cervical cancer screening and STD vignettes too. So, in most US jurisdictions, minors can consent to and receive confidential reproductive health care, including contraception, STD testing and treatment, pregnancy testing, and mental health services without any parental permission or notification. So, the board wants you to know that if a 16-year-old comes in asking for birth control pills or worried about discharge, you don't need to tell her parents. In fact, doing so without her permission would violate her confidentiality. So exceptions exist like for abuse reporting, but the general rule is that pregnancy, contraception, STIs, substance use, and emotional or mental health issues are areas where minor confidentiality is protected to encourage teens to seek care. Then, cervical cancer screening guidelines have evolved with better understanding of HPV and natural history. So, the current USPSTF recommendation is to start screening at age 21, not earlier, if even if the patient becomes sexually active earlier. Because high-grade cervical lesions typically take at least 3 to 5 years to develop after HPV infection. So, from age 21 to 29, screening is with cytology alone every 3 years. From age 30 to 65, the preferred strategy is primary HPV testing every 5 years, though co-testing HPV plus cytology every 5 years or cytology alone every 3 years are acceptable alternatives. Sexual orientation does not change any guidelines. Even women who have sex exclusively with women should follow the standard screening schedule because HPV can be transmitted by skin contact, and many women have had past male partners as well. Um, Adequate pap smear should contain your endocervical or metaplastic cells from the transformation zone. If these are absent, the sample is less reliable. In a low risk patient with prior normal results, you can repeat cytology in 1 year, but in a high risk patient like prior abdominal smear, immunosuppression, or HIV, you should repeat in 4 to 6 months to ensure the transformation zone is adequately sampled. PAP results, they are reported using the Bethesda system, ASCUS. This is atypical squamous cell of undetermined significance, the most common abnormality, and typically managed by reflex HPV testing if it was not done initially. If high risk HPV is detected, proceed directly to colposcopy. If HPV is negative, repeat cytology in 1 year. LSIL, or we call it low-grade squamous intraepithelial lesion, it corresponds to CIN1 or HPV effect and often regresses spontaneously. So acceptable management is either repeat cytology at 6 and 12 months or HPV DNA testing at 12 months. If high-risk HPV is present or cytology worsens, you move to colposcopy. Then let's go to HSIL, high grade squamous intraepithelial lesions. It encompasses your CIN 1, 2, and 3, moderate dysplasia, severe dysplasia, and carcinoma in situ. And all of these require treatment. All of these, either ablation with cryotherapy or laser, or excision with LEEP, or cold knife conization. LEEP is the treatment of choice in most settings because it provides a histological specimen at relatively very low cost. So, LEEP and cone biopsy has some obstetric risks. Removal of cervical stroma increases the chance of cervical incompetence and preterm birth by roughly 2 to 3 times in subsequent pregnancies, particularly when larger volumes of tissues are excised. So, in a pregnant patient with a history of cervical surgery for dysplasia, you measure the cervical length by ultrasound in the second trimester and monitor for signs of early shortening if there is a history of prior preterm birth or recurrent second trimester loss or placement of cervical cerclage around 13 to 16 weeks can reduce the pregnancy loss from incompetence. So, the most important common acute complication of cervical conization or LEEP is bleeding, which can happen during or after the procedure. So let's connect some STD screening and treatment here. USPSTF recommends universal screening for chlamydia and gonorrhea in all sexually active women aged 24 and younger, and in women 25 and older who are at increased risk. Factors like your multiple partners, new partner, inconsistent condom use, or a partner with known infection. Chlamydia is the most common bacterial STD here. It is often asymptomatic, and it can lead to pelvic inflammatory disease, ectopic pregnancy, and infertility if you don't treat it. First line treatment is a single dose of azithromycin 1 gram or doxycycline 100 milligram twice daily for 7 days. Doxy is contraindicated in pregnancy, so pregnant women with chlamydia should get azithromycin. Gonorrhea is also frequently asymptomatic. Usually, we diagnose it by NAT, nucleic acid amplification testing on vaginal, cervical, or urine samples. Um, Treatment is evolved now because current CDC guidelines they recommend intramuscular dose of ceftriaxone, 500 milligram. Um, if the patient is under 150 kilogram body weight, well, we don't need a second oral agent routinely. It needed to complicate gonorrhea as of recent updates. So co-infection is common. So empiric treatment for both is reasonable if the NAT results are not immediately available. So you have to treat both of them. Condyloma acuminata or anogenital warts, they're caused by low risk HPV, typically 6-1. Clinically, they appear as flesh-colored, verrucous, or papillomatous growths on the vulva, vagina, or cervix. Um, the thing is, application of acetic acid turns them white, which is a classic bedside diagnostic clue. So it can present to you with pruritus, bleeding, burning, or pain. Um, Treatment usually we do the chemical destruction with trichloroacetic acid or bichloroacetic acid, which are very safe in pregnancy and can be applied in the office through podophyllin, and podophylox is also the typical agents that but they're contraindicated due to in pregnancy due to potential toxicity. Imiquimod can be used as well. This is an immune modulator, can be applied at home. Surgical options we have cryotherapy is the number one, electrocautery, a laser, and simple excision can be done. So during some pregnancy, large or symptomatic condyloma can be excised, but small lesions they're often left alone as many regress postpartum. So also cesarean delivery is not routinely indicated for condyloma unless the lesions obstruct the birth canal or are so large that they would bleed excessively during the vaginal delivery, right? So this is all about the basic guidelines you should know on for your step one and step two.